it is my duty to invite the chairperson of this entire program, Lions District 306B1 Sri Lanka, past district governor, Lion Shirley Tisera. Over to you, chairperson, to officially commence with this great initiative and the program for the betterment of the world. Over to you.
Thank you, Dr. Jivanta. I call this meeting to order. As mentioned by you, it's a discussion on is ivermectin an effective treatment for COVID-19. So let me first of all request our district governor, Raj Kumar, to deliver the welcome address.
Chairperson of today's meeting, past district governor Lion Shirley Tisera and gracious lady Lion Anita, immediate past district governor Haj Lion M.M. Razik and gracious lady Rizana, first vice district governor Lion Dr. Anoma Vijayasinghe and part-time service past district governor Lion Lakshman Vijayasinghe, second vice district governor Lion President Peter and gracious lady Lion Savitri, international resource persons, Professor Saroj Jayasinghe, Dr. Pierre Kory, Dr. Tess Laurie, Dr. Lenny Da Costa, all the past leaders of District 306B1, doctors, lions, Leos, and ladies and gentlemen. Good evening to all of you. At the outset, I would like to thank the chairperson for giving the opportunity to deliver the welcome address for today's COVID-19 awareness program. On behalf of Lions Club's International District 306B1, I warmly welcome all of you who are present here today through the Zoom platform, where we are going to discuss on the topic, is ivermectin an effective treatment for COVID-19?
Thank you, District Governor Raj Kumar. My dear friends, we have seen untold suffering and death, families torn apart, unemployment and loss of careers, loss of livelihoods, our inability to greet each other, not being able to see smiling faces when on the road, inability to help someone fallen by the wayside. This, you will agree, is against the grain of our ancient civilization and our culture. And to this, the inevitable rise in crime. My dear friends, we have to look at all options and solutions and hope for the best. This is no longer a health issue. It is also a social issue of huge proportions. This is why the Lions District 306B1 had to step in to offer an independent platform to discuss any available means to overcome this tragedy. To pose the question for discussion, is ivermectin effective treatment for COVID-19? We are the world's largest and most active service club organization and recently selected as the world's #1 NGO by the United Nations and the Financial Times on the criteria of accountability, transparency, communication skill. We are a non-sectarian, non-political, non-religious, and non-profit entity and ideally suited to offer this facility. Welcome all of you. We have participants from many countries joining us today, live on Zoom, Facebook, and YouTube. We wish all of you a very productive and rewarding experience. We on our part have secured the expertise of 4 of the finest and most recognized medical professionals in the world. They, together with all our very eminent and knowledgeable participants, will surely result in a most rewarding and satisfying outcome. Thank you for sacrificing your valuable time to participate in this program and to share your knowledge and experience. A brief self-introduction before we get onto our main program. I am Shirley Tisera, a past district governor of Lions. I have been involved in many national level programs since 1986. Talking of health-related activities, I headed the civil society effort in prevention of drug and substance abuse from 1986 to 2005. Prevention of HIV/AIDS from 1992 to 2000. Awareness and prevention of dengue fever in 1995, and then as focal point for the Global Fund From 2012 to 2014, I overlooked the efforts in prevention of AIDS, tuberculosis, and malaria in 11 countries in the Southeast Asian region. The program today will comprise 4 sessions of 20 minutes each, followed by a 10 minutes of question and answer after each session, and an extra 20 minutes of question and answer after the final presentation. Questions will be taken only on chat in Sinhalese, Tamil, and English. We have a most efficient moderating team comprising Lion Dr. Jivanta Perra, Lion Diana Sanatunga, Lion Manjula Ranasinghe, and Lion Mairuthan. Thank you very much, everyone. Hope we have a most rewarding discussion and iron out any misconceptions that exist. Let Sri Lanka and the world benefit from our deliberations. We will now get on to our technical sessions. And may I, at the next item on agenda, request Lion Dr. Jivanta Perra to introduce our first presenter. The subject is issues and challenges faced by Sri Lanka, Professor Saroj Jayasinghe.
Thank you very much, Chairperson. It is my pleasure of introducing the first faculty member for today's this very important session. And Saroj Jayasinghe is an emeritus professor of medicine, University of Colombo, and currently works as a consultant to the Department of Medicine, Sabaragama University of Sri Lanka. He qualified with MBBS honors from University of Colombo and has MD Colombo and MD by thesis from University of Bristol and also MRCP UK. He is a fellow of the Royal College of Physicians London and the Ceylon College of Physicians and the National Academy of Sciences of Sri Lanka. In 2016, he was awarded his third doctorate, a PhD, by the University of Colombo. He was one of the longest serving consultant physicians at the National Hospital of Sri Lanka until his retirement in 2021. During the past 18 months, he has collaborated in several projects on COVID-19. These include describing the origins of the pandemic using systems approaches, working on mathematical models on the epidemic, describing its clinical features of the disease, analyzing the ethical issues of the crisis, exploring controversial therapies including Ivermectin, and development of medical devices to access endothelial dysfunctions. During the last 18 months, he has 14 peer-reviewed publications, topics related to COVID-19, and has advised several stakeholder groups and policymakers. My dear respected participants from live Zoom platform and also through Facebook Live and YouTube Live, let me present the first faculty today, Professor Saroj Jayasinghe from Sri Lanka, to share his experience on issues and challenges faced by Sri Lanka related to COVID-19 to set the tone for today's discussion. Over to you, Professor Saroj.
Thank you very much. Let me first begin by sharing my screen. I must first thank the Lions for inviting me to deliver this presentation. And in my first slide, I've given the topic, issues and challenges faced by Sri Lanka. The views which are present today are my own and not related to the institutions which I'm affiliated to. I have no conflicts of interest to declare. And today is the death anniversary of my late father, who himself was a Lion, and I dedicate this to him. So I will begin by giving you the challenge. I think the challenge we have is that we've had a very successful vaccination campaign, which will take another 4 to 6 weeks for people to have adequate levels of immunity. And when adequate levels of immunity is there in the population, we expect the transmission rates to be less. And because a large number are vaccinated, the number of people who are dying would be less. But the complicating factor, of course, is the Delta variant, which is able to circumvent some of the vaccination. But nevertheless, the vaccination, we know, will reduce the amount of people dying. Even if you get COVID, you will not, the chances of you dying would be less. So to begin with, I am firmly on the side of vaccination as a main strategy. And there is no alternative in my book, as far as I'm concerned, that vaccination is the important one, and certainly other options should be explored. Now we need other options, especially during the next 4 to 6 weeks, because we are still vulnerable. And as you all know, even if you are fully vaccinated, you get your second vaccine today, you will still take another 2 to 3 weeks for you to have adequate levels of immunity. So we are having a vulnerable period, and Sri Lanka is unique in having that vulnerable period. This is not about a country which has got people who are anti-vaccine, large numbers not getting vaccinated. This is a country where we've got vaccinated, people are taking the vaccine, but we've got a vulnerable period. And during that vulnerable period, the stakes are high. So what are we going to do to reduce the speed of spread? Because the speed of spread is the key. If less numbers get the infection over a prolonged period, the hospitals are able to manage them. The problem we have is that if a large number of people fall ill suddenly, the hospitals cannot manage them. So we have to reduce the speed of spread as well as the numbers. So that's why the government has quite rightly taken the stand of limiting interprovincial transport, continuing to disallow crowded events, insisting on masks, physical distance, and requesting people to avoid crowds. And of course, I personally feel that we should also request people who have not been vaccinated not to go out over the next few weeks, right? So you allow only the vaccinated people to go out. And then we come up with this question, what's the role of ivermectin? And this is the cartoon I drew to try and explain to you the situation. So you've got the Delta and the COVID epidemic chasing Sri Lanka, which is vaccinated, trying to cross a bridge using ivermectin, and will be home and free, hopefully, within another 4 to 6 weeks. So therefore, the importance of exploring all possible options. And the option we are going to discuss today is ivermectin. And remember, the stakes are high. That's why you've got alligators there. It's a short period, 4 to 6 weeks. And if we just get the vulnerable over during this 4 to 6 weeks, I think as a country, we have won. So my next few minutes, I will spend on asking these questions. What is ivermectin? People think that this is something which has been taken off the shelf and taken from the veterinarians and so on. Why consider using it in COVID? What's this whole concept of strength of evidence? And I want to shift the question to a medical decision-making one. What do you do when your evidence is inconclusive? And then apply that to Sri Lanka. So what is ivermectin? Well, it's interesting because it was found in a particular fungus growing near a golf course in Japan, not found anywhere else. And two of them who discovered this won the Nobel Prize in Physiology and Medicine. The compound was isolated to some extent in Japan, sent to US, and that was Merck Laboratories, which isolated the compound. And the important effect was that it was able to cure onchocerciasis, which is called river blindness. And you see the parasite in the eye, and that's what happens. It's the eye which gets affected, and the areas which are affected are shown in the map. So large numbers do get affected. In addition to ivermectin being used in river blindness, Sri Lanka also has a stake, because Sri Lanka used the ivermectin, some of the original studies in relation to ivermectin in filariasis was done, and that was late Professor Ismail who did some of the work, and I was also involved in some of this work. So this is not a sort of a drug which we have never used in Sri Lanka. So it's used in other conditions, even in head lice, scabies, and other forms of microfilaria. And it's been in the essential drug list from 2019, and perhaps about 4 million doses of the drug have been used. So this is not something which we have not used in the medical profession. This is something which has been used in the medical profession. So why consider using ivermectin? Again, people seem to think that someone has just woke up in the morning and thought that we should be using ivermectin on COVID-19. Well, that's not the reason. There are studies in the laboratory, studies done on animals, and studies done on what we call computer simulation of molecules. All these have shown potential effects of ivermectin in COVID. So if you talk of the laboratory evidence, it's on cell cultures, and you find these few diagrams might be a bit complicated, but that's your cell membrane, that's the nucleus, the green one, and you've got the virus coming in, and you will, just to show you the sorts of pathways which are involved when the virus comes in and how it affects this pathway involves the lung also, and then to show you that the drug affects several aspects or pathways related to the entry of the virus into the nucleus. Second thing, when they looked at what we call in silo tests, where you use molecular docking, where you simulate, you find that ivermectin is a drug which potentially has an effect against COVID. So that's the second bit of evidence. Third bit of evidence comes from animal studies, and where this poor golden Syrian hamster was found to be protected to some extent by ivermectin. So it's a drug which has a laboratory basis to be effective, and then we get on to clinical studies. And our clinical studies are related to clinical trials, observational studies, meta-analysis, and data from populations using ivermectin. Now, the subsequent speakers will talk about this more, but I just want to introduce this concept of strength of evidence. Because in medicine, when you collect evidence and apply evidence, we've got a field of inquiry called evidence-based medicine, and we will look at the strength of evidence. So just because a professor comes and tells you that a particular drug is effective, it does not mean that that is adequate evidence. Similarly, if someone comes and says, I've got 6 patients and I've given ivermectin and they've all done well, again, not enough evidence. You have to do observational studies or clinical trials to say whether a drug is effective or not. And there is a well laid down methodology to do these. So let's talk a bit about strength of evidence. And as I mentioned, ideas, editorials, opinions are the lowest. And the more you study them objectively, the better it is. If you study them over a period, you will have what we call cohort studies. And then we have randomized control trials. That's when the person who is taking the drug does not know whether it's the drug or something else, a placebo. And the person who is testing also doesn't know. So it's a double-blind randomized clinical trial. This is to avoid bias. And you can collect all these control trials and talk of systematic reviews and meta-analysis. So you'll understand the strength of evidence, just like in a court of law, circumstantial evidence, evidence beyond a reasonable doubt, and so on. So we have this concept of strength of evidence. And if you apply this to ivermectin, that's where the issue is. Because based on the current studies, it is giving us different values. There are some studies which are saying it is useful, some are saying it is not useful. And when you collect all these studies together, like the one on Cochrane database of systematic reviews, a very respected collaboration, they say that we are uncertain about the efficacy, low certainty of evidence. Whereas another well-done control trial has shown moderate certainty evidence of a large reduction in deaths. That's the reference number 2 I've given. But certain countries are reporting success with ivermectin, and India is one such. There are several studies in progress, and therefore evidence is still inconclusive. And the following speakers who are following me will lay down and describe to you some more evidence. They will critique some of these papers and also give you more evidence. But I am looking at it from a different angle. I'm framing the question differently. I am framing that evidence of efficacy could be inconclusive, but what should you do when evidence is inconclusive? What are you supposed to do? That's the question I am trying to tackle. And remember, not only is the inconclusive, if we assume it is inconclusive, the stakes are high. I told you, 4 to 6 weeks. Alligators are waiting. Are there alternatives? Well, we have the alternatives like vaccination. We've done everything. We are going to stop crowds. We are going to ask people not to wear masks. But drug-wise, we don't have any alternative. Now, this paradigm of doing something when there is inconclusive evidence comes under the area of decision-making theories. And I think this is where the medical profession is I think they're not clear on the question, because there's a lot of debate trying to say that the evidence is conclusive. I am saying no. Even if the even if your evidence is inconclusive, we have to make a decision now. And what's your decision? So stakes are high because Delta and the vaccination and window of vulnerability, as I mentioned, and there's no effective alternative. And we've got a drug which we call repurposed ivermectin, easy to administer, cheap, safe, used for almost 40 years. Now, when you try to do this sort of decision, make this sort of decision. And this sort of decision is very common in the climate sciences and environmental sciences, because you have to take certain steps before the disaster hits you. So you can't wait for climate change to happen and then turn back and say, oh, I should have reduced carbon dioxide emissions. No, you have to make the decision now. So similarly, you have to make a decision now about ivermectin or any other drug options. And one way of doing it is what we call multiple criteria decision-making methods. Now, there are several methods of making decisions when there are different criteria. I'm going to give you just the principles. So if you want to compare drug B with drug C, you will look at side effects. Obviously, if there are very serious side effects, you're not going to give the drug. You want to see the efficacy. If it is low, you won't use it. If it is expensive, you won't use it. If it is not easy to use, you won't use it. So this is a very simple one. You're going for drug B in this, because everything is good in drug C compared to drug B. But you can make it a bit complicated. Drug A, inconclusive evidence. Now, when drug B, when you talk of low evidence, that is you're concluding that there's low evidence. This is a different ballgame. You're talking of an inconclusive. Knowledge is still evolving, and it's cheap, it's oral drug, it's easy to use, side effects are minimal. Now it becomes difficult whether to choose A with C, because C is supposed to be, efficacy is there. Now, this is what is happening with ivermectin. So if you look at if you apply this criteria, you find side effects, minimal, inconclusive evidence. That is, in 4 weeks, we might get evidence that it is good, or we might get evidence that it is useless. It's very cheap, not much of an extra cost. It's easy to administer. And what's the alternative? Nothing. Alternative is nothing. We don't have anything. We don't have any drug. We don't have anything to offer, right? So ivermectin, therefore, I think has a place. Now, if the stakes were low, for example, if you're trying to use it for a disease like hypercholesteremia, which is going to take long term, and there's no urgency to treat, then you will not use it. But here the situation is different. Stakes are high. You have to make the decision now, and you have 4 to 6 weeks to make that intervention. So based on current status of evidence, I put it to you that Sri Lanka ought to use ivermectin to treat COVID, at least during the next 4 to 6 weeks, when we are likely to be more vulnerable to COVID-19. In summary, we are facing a unique challenge. This is Sri Lanka. We are considering ivermectin because of the laboratory evidence and clinical studies. And I've shown to you why we should be using it at least for the next 4 to 6 weeks. And if it is not effective in 4 to 6 weeks, we realize it. By that time, the danger is gone. We just dump it. But if it is found to be effective and we have not used it, we have killed people. So that's the point I wish to make. And I'm sure the other speakers will now share their views on the evidence of its efficacy. And thank you once again for giving me this opportunity to speak to you. I'm open for questions now.
Number one is, this particular magical drug is now discussed among all the healthcare professions and other people. Then do you have any kind of recommendation for using ivermectin for specific age group, for specific category? Or what are as a GPs, most of us are practicing as GPs. So what are the kind of precautions we should, take prescribing these drugs? Over to you, sir.
Thank you very much. I think my focus has been on treatment, and the Ministry of Health has given the okay for people to be treated with ivermectin, but under supervision of the physicians. So therefore, I would suggest that the physician should be making, or the clinician who is responsible for the patient should be making that decision. And they could prescribe ivermectin for people who have developed the illness. Earlier, the better. So, and because it's a drug which the ministry has not given a blanket authorization, I think it's prudent not to give it to children, those below 18, and certainly there's a contraindication to give it to lactating moms and pregnant people. But it's a relatively safe drug, and you're not giving a very high dose when you treat with ivermectin for COVID. But earlier you give, the better it is. And I know of certain colleagues in the US who are working in ICUs, Sri Lankan ICU intensivists, who are using ivermectin even in the ICU. So that's very severely ill patients are also being given this drug. As for prophylaxis, now that's a moot point. That's something which we haven't really looked at in Sri Lanka, because Sri Lanka, as I mentioned, we are using vaccination. There's no doubt about that, right? But having said that, there are lots of studies, especially coming from India, where short courses of ivermectin have been useful in prophylaxis. That is, if you have got exposed to COVID and there's a high risk, then you give them. There are various dosage regimes they have used in India. One dosage regime I could recall is day 1, day 3, and once a week afterwards. So it's just 12 milligrams. Now, that's one post-exposure. But at the same time, you can use the same sort of regimen for people who are constantly exposed. So India has done that, where people who are exposed to COVID cases are constantly, even despite vaccination, if they're getting exposed, they start taking ivermectin on a regular basis. And I know a lot of Sri Lankan doctors are doing that. A lot of specialists are doing that. A lot of other people are also using it as prophylaxis. Yeah. Thank you.
Thank you very much, sir. So then for the moment, what if I recapitulate what you have mentioned, for the moment, mostly the ministry approved to use it in the clinical practice to treat people, but for the moment, ministry has not endorsed to use it as a prophylaxis. Sri Lanka.
Yes. I think I think that was the correct move, because when we spoke about ivermectin in treatment, our main request was to allow its use by physicians or clinicians so that we reduce the deaths, we reduce people having severe illness. And we did not want to talk about prophylaxis primarily because we did not want to interfere with the successful vaccination effort. You see, unfortunately, if you look at the trends in other countries, there is a large group of people who oppose vaccination for their own reasons, and they are using ivermectin as an alternative to vaccination. We are, certainly, I am not in any way saying that it should be an alternative to vaccination. This will just supplement or complement the vaccination program. So this is why it was a strategic move. We did not talk about, I did not talk about prophylaxis in any of my in any of my letters or communications, because I did not want vaccination in any way to be affected. So vaccination comes first, masks, physical distance, restrictions on mobility, all those come first. But for certain specific instances, other countries, they've shown results. Should we use it is the big question. Yeah.
Right. Okay, so there's another one or two questions. I think we can go for another one or two questions. No? So what is your recommendation to use ivermectin in cases of hepatic diseases and renal diseases? So is there any kind of contraindication or not?
Yes, I think those are people who have chronic illnesses such as chronic severe liver disorders and severe renal disease should not be taking it, because we don't have much experience of using these doses for a period. Having said that, in some countries, they are using very short courses of the drug. Now, usually when you treat, you give a course of 5 days, but there are some countries where they have used just 2 doses of ivermectin given very early. So whether the physician, the clinician wants to take that risk and give the ivermectin initially, even in relatively mild liver disease or kidney disease, that's something the decision has to be made by the clinician. And I think the government has done quite correctly, because they've said, that allow the clinician to make a decision. And again, I must tell you that, the clinicians who do not want to use it, ivermectin, are doing so because of their firm belief in science. There is no medical mafia trying to prevent ivermectin use in Sri Lanka, I can assure you. And I respect the clinicians who have an opposing view, and their opposing view is mainly on scientific grounds. Thank you.
Okay, thanks, sir. I think we can go for one last question. Is it all right?
Yeah, I'm fine.
Okay.
Dr. Danath, Dr. Danath, we can have one question, but there's a very specific question which is related to Sri Lanka with regard to as the schools are starting. I think some of the general public parents also there. So there's a question: if the schools are to open, can a minor dose of ivermectin be given than hazardous experimental vaccine? This is basically asked by a parent. So I should give that question to Professor, because most of the parents, Sri Lankan parents, are a little bit scared as the schools are to be open.
I think I will join I'm also going to ask you the same kind of question. So for the moment, vaccination has been trickled down to the young age groups. So there are certain controversies within general community. For an example, now the vaccination among youth has been drastically reduced. They are asking for specific ban of vaccination. So if you can just take these 2 questions and give answers, I think that would be much more useful for all of us.
Yeah. Point number 1, I think since we are still, the ministry has not okayed it, I don't think we should give it to minors, no one below 18. The idea is that a person above 18 has technically the ability to make a decision whether they want to take ivermectin or not when the physician or the doctor recommends it. So I think no ivermectin below 18 in my book until there's more evidence or we are more familiar with the drug. The second point about vaccination, yes, there are concerns. And you see, our vaccination policies are also well worked out, in the sense we do look at all the evidence coming from WHO and other institutions. And, you see, there are people who think that there could be a major conspiracy in some of these data. But, to be honest, you can't really have a conspiracy of this magnitude. Because there'll be so many people. There's a whole chain of people, involved. So you can't have, this is not just a vaccine being produced in a small laboratory and a few scientists and Bill Gates getting organized and doing this. So I would, my position is that we look at the best evidence we have, be guided by the most representative and least conflict of interest groups. I know WHO, there is a huge, there are issues in those. But at the same time, WHO can't do what they want because all their data is being checked. Now there are things called living guidelines where specialists all around the world are feeding into the information into these. So you can have a healthy debate on this, but I go with the view that if there is a reasonable consensus in the major institutions, and they say it is okay to give the vaccine to young groups, I think we should go ahead with it.
Yeah.
That's my position. And certainly if there's, I know this is controversial, but you have to take a stand.
Yeah. Okay.
Dr. Jeevant, and thank you, Dr. Dayanath, and also Professor Saroj for the excellent presentation.
Okay.
So we will, can I now request the Senthil Nathan to introduce our next speaker, Dr. Pierre Kory, and he will speak on the subject evidence-based arguments. Over to Senthil.
Thank you very much, Chairperson of the project, Past District Governor Shirley Tisera. It's my privilege and honor to introduce our next speaker. Pierre Kory, MD, MPA, is the President and Chief Medical Officer of the Frontline COVID-19 Critical Care Alliance. Dr. Kory is also a leading critical care physician currently working in an intensive care unit in Wisconsin, north central of United States. A renowned pharmacologist, teacher, medical researcher, Dr. Kory is the former chief of the Critical Care Services and medical director of the Trauma and Life Support Center at the University of Wisconsin. He is considered one of the world pioneers in the use of ultrasound in the diagnosis and treatment of critically ill patients. Dr. Kory was also one of the US pioneers in the research, development, and teaching of performing therapeutic hypothermia to treat post-cardiac arrest patients. Prior to his move to Wisconsin, Dr. Kory worked in a New York City hospital where in 2005, it was the first in the city to begin regularly treating patients with therapeutic hypothermia. This practice led to a network of 44 regional hospitals to adopt these cooling protocols that have served countless lives. Known as a master educator, Dr. Kory has won numerous departmental and divisional teaching awards in every hospital he has served. He has delivered hundreds of courses and invited lectures throughout his career. Now let me welcome Dr. Pierre Kory to talk about evidence-based arguments, Ivermectin, and effective treatment for COVID-19. Over to you, Doctor.
Okay, thank you. I'm going to share my screen. Let me know if this works.
Yes, doctor.
Is it filling the screen?
It's
Yes,
working.
yes.
It's working.
Okay. So, yeah, so I'm going to talk about the evidence. I'm going to speak specifically on ivermectin and the evidence-based supporting it. So, when we talk about an evidence base, especially when you're studying the efficacy of medicine, one colossal error that I see being made across the world, some of it is on purpose and some of it is just a benign misunderstanding. But if you look at the totality of evidence, when you assess all the aspects of evidence supporting efficacy, if you look at the lower left corner, it seems the entire world is focused only on the randomized clinical studies. And they argue on these and they talk about meta-analyses and they ignore all of the rest. And what I want to go through with you today is I want to walk through all of those building blocks of the evidence base for the efficacy of ivermectin. And I think you're going to be left, no, not I think, you're going to be left with an overwhelming conclusion that this should be standard of care worldwide, period. And I will show you why that is. Because I also will say, and I'm sorry to be negative here, but ivermectin is a drug which is wickedly effective in this disease. It is surrounded by corruption masquerading as controversy. I'm sorry, I'm going to repeat that. It is an evidence base which is literally driven by corruption. Everybody is arguing about the randomized clinical studies, and it leaves it as a controversial or inconclusive drug when the opposite is true. And I'll show you why. So we're going to go through today, I'm going to go through the basic science studies, which is over 10 years of models showing its efficacy against numerous viruses. It's not just effective against COVID. The animal models which support those in vitro studies, showing increased survival and decreased inflammation in animals given ivermectin in coronavirus models. The pharmacology, which is that it's unparalleled safety. I will tell you, this is a drug that's been distributed across the world for decades, to young, to old, even to pregnant. We don't have great data on pregnancy, but it's generally thought safe in pregnancy. Then the clinical experience case series, which is the first thing that highlighted its efficacy, and then all of the clinical trials, the meta-analyses, and for me, the most compelling evidence is the real-world epidemiologic evidence. So I'm going to walk you through this evidence base. Now, keep in mind, right? We all know ivermectin. It's known for being an anti-parasite drug, and the discoverers won the Nobel Prize because it literally transformed the health status of huge and numerous regions of the world and millions of people by eradicating at least 2 important parasitic diseases and more. So we know that it's effective as a drug against parasites. However, we know now that it's an antiviral, and it's a very potent antiviral. So over 10 years ago, studies started to come out where they tested ivermectin in cell culture models against numerous similar RNA viruses. And it was shown to be effective at stopping the replication of Zika, dengue, West Nile, influenza, and HIV. And if all of you know what happened last, April of 2020, which is that investigators in Monash, Australia, they published a study showing that in a cell culture model, it was also effective against SARS-CoV-2, which is not surprising because there was 10 years of studies showing that it was effective as an antiviral. The most important thing about ivermectin is that it has multiple mechanisms to stop viral replication, but it is also known as a very potent anti-inflammatory drug. So it has antiviral and anti-inflammatory properties. And as my colleague and mentor, Paul Marik, says, it's like a gift to us. If you were going to design a drug to treat this disease, which has numerous phases, beginning as a viral syndrome and then progressing into a hyperinflammatory phase in pulmonary, you would want something that's antiviral and anti-inflammatory. And so a lot of these mechanisms have been elucidated prior. And the anti-inflammatory mechanisms are well known. And so, there's a very strong basic science mechanistic support for why ivermectin should be effective. It's not a fluke. It's not like we just tried something and it worked. It was already very well known as possibly being a potent antiviral. And that's why people talked about it since the beginning. There's a few animal studies, and there are more being conducted. I'm aware of more. But the most important for me was this is not a coronavirus model, but it was a very similar coronavirus called the mouse hepatitis virus. And it's a coronavirus which destroys the livers of mice. And so in this mice model, they infected a number of mice with this virus, which literally causes diffuse hepatocellular necrosis. and they treated 20 with ivermectin. And what they found is that the non-ivermectin treated died from liver failure, whereas those treated with ivermectin showed very little damage and pretty much no difference from the uninfected controls. So a really powerful animal model. And then a similar one in golden hamsters showed a lot less symptoms, anosmia, and reductions in cytokines. So again, basic science, really strong evidence base. Animal models also supportive, right? But we all know, right, that very few molecules make it from the bench to the bedside. But that's what I'm trying to take you through today, is that we're going from the bench and we're going to get to the bedside, right? So we went from the bench, we went to animals, and then let's go to what happened in Dominican Republic. Because for me, what happened was is in the first trial that was published, this wasn't a trial, it was actually a case series. And I got to meet Dr. Morgenstern and Dr. Redondo, who they own and run clinics in the Dominican Republic. And what happened is in March of last year, they met their first tourist who is severely ill with COVID. And a doctor knew somewhat of the efficacy of ivermectin and asked for permission to treat the patient with ivermectin. And they saw a really potent clinical response. And it was so dramatic that they said, this thing works in COVID. And they started a protocol in all of their urgent cares and emergency rooms where they consecutively treated patients with ivermectin. And what happened is they reported on their experience, which was profound. They found that in the almost 2,700 patients who came to their emergency room in an outpatient status, only 16 ended up needing the hospital. Nobody died. The two that required ICU admissions from the get-go, actually 30% died. But if you look here, 300 that were immediately admitted to the hospital, only 1% died. And the 111 who went to the ICU, 30% died, which is similar to world statistics for the severely ill. And it shows that, you know, when you get to the late phase disease, obviously you're going to need more than ivermectin. But this is a stunning result in the fact that nobody died out of 2,700 consecutive patients. But again, that's a case series. And I'm trying to build, you know, the pyramid of medical evidence to support the efficacy, right? It starts from basic science, animals, case series, clinical experience, and then we go into the trials. My personal clinical experience is that since I did the review paper and since we started to see the trials coming out, and by the way, I'm a latecomer to ivermectin. I did not use ivermectin in my practice until November of 2020. And that's when Professor Marek and myself, we were reviewing the trials, and we found this incredible reproducibility and consistency in benefits. And I adopted in my practice, and I will tell you, within the first patient, I could see its efficacy. Because what I have found is when I treat patients, particularly when I start early, whatever is bothering them in the syndrome of COVID, at least one, and oftentimes multiple, clinical symptoms will start to be mitigated or disappear within 24 hours, and sometimes even within 12. So patients who've had fevers for a week, they will defervesce, the fevers will go away. People with chest tightness or fatigue, they'll feel a little bit more energy. And again, could be placebo effect, fine. But I will tell you, it's very hard to disappear a fever from a placebo. And so I've just found this incredible, robust physiologic responses. And I will tell you, none of my patients have died and none have gone to the hospital. However, I will say the fact that they didn't go to the hospital is because I've used multiple other agents when they're severe disease or late. Because a lot of patients, by the time they get to me, they're day 7, they're day 8, and they need combination therapy. You can get away with ivermectin alone if you treat immediately upon first symptoms. But I will tell you, this disease moves fast. Some of the variants move faster, and oftentimes you will need combination therapy. But my clinical experience has been profound in the use of this drug. And the other thing is, that's also a little bit of my, I get a little bit resentful when people discuss the efficacy of ivermectin who have never used it in any patient. They have no clinical experience. They have no sense of what this drug can actually do, and yet they opine very strongly on whether the drug works or not. And I will tell you, it's not just my clinical experience I'm basing this on, but I think it's important. I have yet to meet a doctor anywhere from around the world who has told me that they've adopted it in their practice and they found it ineffective and they stopped using it. I'm waiting for that doctor to come up and say, it doesn't work, I tried it and I stopped using it. So that's the clinical experience. Now, Let's talk about pharmacology. It is one of the world's safest drugs. I don't want to hear about any of these concerns about risks, and I'll tell you why. Because there's numerous studies in COVID at very high doses, at prolonged durations, and there's absolutely no signal that there's a lack of safety. So, for instance, it's been given across the world for decades, distributed across continents in the billions of doses. Almost 4 billion doses have been administered. The WHO guideline for scabies says the majority of side effects are minor or transient. A recent toxicologist, world-famous toxicologist, did an expert review, and he found that severe adverse events are unequivocally and exceedingly rare. It is not considered toxic to the liver, it's not considered toxic to the kidney, and it's not considered toxic to the lungs. In the 4 billion doses administered, there was 2 case reports of a hepatitis which resolved without treatment. And it was not even clear that it was due to the ivermectin. So all of these concerns about liver and kidney and lungs is absolutely misplaced. There's no evidence base supporting that. Further, there is no proven death due to ivermectin in any overdoses. There is about 5 or 6 case reports of massive overdoses of ivermectin. It caused neurological problems. The patients were admitted to the hospital, and within days, they recovered without specific need for therapy. So it can make you sick if you overdose, but there's no proven deaths associated. And this has been well described and documented in numerous reviews. The cost of ivermectin, right? It's an essential medicine to the world. Right now, to manufacture in India, a 12 milligram tablet, it costs 6 US cents. It's one of the least expensive, most widely available, no refrigeration needed, and no administrative cost. It's literally probably the most equitable drug that you could think of to address a pandemic. Now, we talked about basic science. We talked about animals. We talked about clinical evidence. Now let's go to the trials evidence base. Really important here is that currently we have 64 controlled trials. 32 of them are randomized controlled trials. I will also tell you 16 of them are double-blind randomized controlled trials. These trials now total 26,000 patients, and they find consistent and reproducible benefits in the prevention, early, and late treatment, and it's a life-saving drug. And so there should be absolutely no question about this trial's evidence base. What you do is you do find people who focus only on the randomized, and then they only look at a subset, and then they find that it's inconclusive. It's ridiculous when you think of the totality of the evidence. And so briefly, I want to show you what that evidence is. Now, before we go through this is one of the most major insights into evidence-based medicine, where I will tell you, in my experience, 98% of doctors trained in the last 30 years are not aware of this. But got news for you folks. Observational controlled trials and randomized controlled trials throughout the history of evidence-based medicine largely find the same effect, size, and direction. So for all of the, what I call the RCT fundamentalists, which is these people obsessed that you need a randomized controlled trial, that is simply not true. When you look back over numerous disease models, thousands of studies over decades, and you compare a disease model studied with an observational control trial and one with a prospective randomized control trial, it is very hard to find the difference in what they find. When the medicine doesn't work, they both find it doesn't work. When medicine works, they both find it works, with maybe a slight, very small difference in effect size. And so when I have to, through this journey, I have to sit here and argue about these randomized controlled trials, and they're unsatisfying to some people, I think we are ignoring a massive and really important part of the evidence base. So much so that the American Thoracic Society, which is sort of the ivory tower of the ivory towers of the United States, and it's a college that I used to belong to, but they actually did a policy document where they reviewed this, and they understood, and they said, conclusion, observational studies should be considered in developing clinical practice guidelines and in making clinical decisions. So to argue about RCTs is ignoring a huge part of a very important size of the evidence base. So if you look at this, this is from the website IVM Meta. I only do this for a visual. It's a compilation of the studies. And if you look all the way to the left, you'll see the numbers of randomized, double-blind, randomized, and the ones that don't have that, they're observational. But look at this early treatment. The vast majority of randomized controlled trials and a huge number are double-blind randomized controlled trials. When you look at the figure with the boxes and the lines, the middle line, right, is the line of no effect. To the left of it means that there was a benefit measured in that study. And when you look at the confidence intervals, if it crosses 0, it means it had a wide confidence interval because it was generally a small study. So it was underpowered to find a statistically significant result. However, let's leave alone the statistical significance. Look at the remarkable consistency and reproducibility of benefits being measured. Very, very large benefits. You see how much to the left they are, with rare exceptions, and there's only 2 on this, or actually there's 4, but out of like the 30 trials here, consistent, reproducible, large magnitude benefits, and quite a few of them were actually statistically significant. The larger ones find statistical significance. And when you summarize them in a meta-analysis, you find on average, you see 70% improvement in any number of outcomes. Now, this is not a pure meta-analysis where it's just looking at one single outcome, but you do find in these studies looking at primary outcomes, you find this consistency and reproducibility. So that's just in early treatment. What about late treatment? You find the same consistency and reproducibility. However, the magnitude is less. And we know that about any acute disease. The earlier you treat, the better. And so if you start late, you're not going to have as profound benefits. But in a number of trials, you're seeing still consistent reproducible effects, especially on mortality. A lot of these outcomes were on mortality. And so you're finding that it works really great early, and then it also works late. Look at the impacts of mortality. Is there a drug that we have aside from dexamethasone in that one study in late phase disease which shows a dramatic mortality improvement? We do not. And if you look at ivermectin and you summarize all these, you find these very large impacts on mortality. It is a life-saving drug based on those properties that I talked to you about. Can someone tell me if I'm running out of time or if I have 2 minutes left? I don't know how long I'm going, but just let me know and I can go faster. And then I hear complaints about, oh, none of the studies are peer reviewed, they're in preprints. Well, if you look at the preprints, you look at the peer reviewed, you see the same pattern. Benefit, 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 large magnitude, early treatment, and slightly lower later. And these are all peer reviewed studies. So when I have to hear complaints that they're not peer reviewed, there's no difference whether it's being peer reviewed or on a preprint. Prevention of COVID-19. This drug has shown superior efficacy to vaccines, especially when you see the efficacy of the vaccines that are waning now. Remember, vaccines have one mechanism of action, which is they produce a spike protein and a portion of it, and so you can make an antibody. Whereas ivermectin has numerous mechanisms of action preventing transmission. For me, the most prominent and the most powerful one is that it is a drug that binds tightly to the spike protein. So if you can bind tightly to spike protein, you prevent its entry. And in these studies where they take it regularly, and the more powerful studies which offer almost perfect protection, those are where they took it weekly. And if you take it less often, you have a little bit less. But on average, you're finding an 86% chance of protection from getting the disease if you take it regularly. You know, the prior speaker mentioned in India, they use this in healthcare workers, especially in Uttar Pradesh, which I'll talk about in a second. But they have thousands, and there's millions of doses that have been taken by healthcare workers who's fighting this pandemic. So it's wickedly effective, not only in treatment, but also in prevention. Our paper, the one that I wrote with my group, was published April 30th, and it was peer-reviewed, rigorous peer review by 3 senior governmental scientists. And we concluded that this should be immediately deployed in the prevention of treatment worldwide. It did not happen. And I can talk a little bit about why that didn't happen, but we are not alone. A number of other expert groups. So my colleague, Andrew Bryan and Tess Laurie, they did their own. These are experts. They've been working for Cochrane Library, the WHO. They've been developing guidelines for decades. And they independently performed their own systematic review and meta-analysis, and they found the same conclusion. However, they've been attacked and we've been attacked. I can only stand on our credibility, our seriousness, and our primary trust is in the patient. And I will tell you why we've been attacked. But I just want you to know that we are not alone. There's numerous groups around the world. So Satoshi Omura, the Nobel Prize winner, his institute, they also did a masterful comprehensive review, concluded the same. The Bird Group, which is an international consortium that's centered in the UK, they also voted, reviewed the evidence, and found the same. Systematic deployment. A group from Spain and Italy, ourselves in the US, and then early on the Unitaid WHO preprint. But since then, they have the WHO does not recommend outside of a trial, and I can talk about why that happened a little bit later. But this is the most recent. This was by a expert researcher who's worked for the WHO for decades and a number of disease models. And in that review, which is 24 randomized controlled trials, they found consistent, reproducible, statistically significant, reduced inflammatory markers, time to viral clearance, which was dose dependent. You have to understand that when a medicine is dose dependent, it is another pillar in the efficacy. If you can show that higher doses lead to larger effects, it is almost an unassailable sign of efficacy of a drug. They also found time to clinical recovery was reduced and reduced mortality. Now, this has come under some attack because one study is considered fraudulent. That fraudulent study is maybe fraudulent, it may not be. It has not yet been determined. However, the whole world is saying that all the evidence base is fraudulent. I don't care if it's fraudulent or not, because I don't rely just on those randomized controlled trials. And even if you remove that trial, the impacts are still the same. They're slightly smaller in effect size, but they are still there. So I don't like to hear about anyone talking about fraudulent, because it's just one part of the evidence base. And then the problem that I also find in this corruption around this drug is that, I am sorry, but there have been publications which I believe are planted, and they were done purposely. And the reason why is I told you there's 32 randomized controlled trials available. These are recently published, especially the Cochrane. How many did they review? 14 of the 32 and 14 of the 24 that Hill reviewed a month earlier. You all have to tell me why these groups are using such a small number of randomized controlled trials. And when they do that, they find that the benefits are there, but not statistically significant. So then they conclude that it's inconclusive. It's nonsense and it's corruption. And then if you look at the high impact journals, the only studies being published in high impact journals are ones that are inconclusive. They are not publishing positive studies. And I will tell you that is a selection bias that these journals are doing. And how do I know that? Because I know many of the authors and investigators of the positive studies, they cannot get published. And when you look at the ones that they are publishing, although they're not statistically significant, they still find benefit. When you put them into meta-analyses, they actually make the meta-analyses stronger. And for those of you who are students of evidence-based medicine, it's long been considered that the highest form of medical evidence is a meta-analysis of randomized controlled trials. And so these trials, all done in South America, they have challenges. What are those challenges? Well, first of all, one of them, the Together trial, even though it showed an 18% reduction in mortality, it was not statistically significant. But keep in mind, they were battling the gamma variant. And the gamma variant is wicked and violent, and the doses were insufficient. My colleagues in Brazil battling gamma variant used much higher doses for much longer durations. However, they still found a reduction in mortality. And the other problem with these trials is that ivermectin is widely used amongst the population. So if you do a trial in South America, you know, you have to wonder why you're not finding these amazing results that other areas do, is because it's over the counter and many people know it works. And so when you get sick, oftentimes they take ivermectin. And in some of the trials, they did not exclude you. So again, it angers me when people are arguing about these RCTs in these small subsets or focusing on a single trial. You need to look at the summary and the totality of the evidence. Just to give you an idea of how corrupt and what a farce this is, that we're discussing whether ivermectin works or not. Let's keep in mind the Infectious Disease Society of America, another pillar of the ivory towers. In their last decades of guidelines, they reviewed them, and they found that in their last 44 guidelines, in a number of infectious diseases, they found 6,000 graded recommendations. The vast majority of recommendations were based on expert opinion only, which is level 3 evidence. A third were based on observational studies, and only 16% actually had one single randomized controlled trial in order to make a recommendation. If you look back at my evidence base for ivermectin, it has 64 controlled trials, 32 randomized, another 32 that are observational, and yet the IDSA still can't make a recommendation. Does anyone find that absurd or a farce? It is a complete farce. And if you look at how scabies, how ivermectin was approved for scabies and spondylolisthesis, well, seems like when we weren't in a pandemic, the WHO actually approved ivermectin based on 10.
Okay, if I delay your presentation, coming to you for about 10 minutes, because I don't want to stop him from talking.
Can you sorry, doctor, you can carry on.
Oh, I can carry on. Okay. Hopefully I'll finish the next 3 to 5 minutes. So just to show you the anomalous behavior and aberrant behavior, and what I will call you, I'm going to speak plainly, corrupt behavior on ivermectin. There's a huge opposition to ivermectin, but look at what happened. Ivermectin was approved worldwide for the treatment of scabies based on 10 randomized controlled trials involving only 852 patients. And what's even more crazy is that it was tested against permethrin cream, and it was not even as effective as permethrin cream. The reason why it was approved is because it's much easier to administer in someone who has scabies. Permethrin cream, you literally have to coat the body with this cream, multiple times, whereas ivermectin is a pill. And that's why it got approved. It got approved because there was RCTs showing that it worked, but less effectively than what it was compared to, okay? And then for spondylolisthesis, it got FDA approval, and it was approved based on 5 RCTs and 591 patients. Whereas back in March, we had 21 RCTs and over 2,700 patients, and yet the world cannot seem to agree to recommend ivermectin. It is a corrupt exercise. Now, let me finish. So guys, I went through basic science, animals, case series, observational and randomized controlled trials. Let's see how it's working in the real world. There's 4 regions of the world which actually collected data and has shared the data with the world. These are the models that I think the world should follow. The first preprint that showed up, which is the Mexico City, which is their institute, which is IMSS, they did a massive test and treat program, and they collected data on thousands, over 100,000 patients in Mexico City, 2 states in Argentina, and then what I call the miracle of Uttar Pradesh. So let me go through that really briefly. Number one, what happened with Mexico City is they simply employed ivermectin in early treatment kits, and they distributed during a massive surge last winter when they were running out of oxygen and the hospitals were running out. And what they found is after the distribution of kits, when they compared it to either the month prior or to those who didn't get the kits in the city, they found around a 70 up to a 76% reduction in hospitalizations. They literally emptied the hospitals after distributing this widely to the highest risk areas in Mexico City. So this massive, massive impact. Literally, you were saving 3 out of 4 people from going to the hospital. Another state in Argentina, Misiones, they did the same. Early treatment. And by the way, this was high dose. This was 0.6 milligrams per kilogram for 5 days. They collected data on liver function tests, on adverse effects. They found no problems with high doses for 5 days. What they found was 74% and up to an 88% reduction in deaths. So again, 3 out of 4 reduced hospital and 88% less people died. This is a life-saving medicine. You can see it working in the world. Another state, La Pampa in Argentina, they just put their results out in a paper, and they found, this is in the unmatched groups, which is just, it was an interesting study because all the patients with ivermectin were much, much sicker than those that didn't. And actually, when you match their severity, the chances of ICU or dying was up to like 66%. But in the unmatched groups, they found a 30% lower chance of dying, 40% lower chance of going to the ICU. Again, huge benefits amongst populations. Now, we have to talk about what I think is one of the most historic achievements in the history of public health, which is what happened in the state of Uttar Pradesh in northern India. Keep in mind that Uttar Pradesh is one state of 241 million people, okay? It's 2/3 the size of the United States. It's a single state in Argentina. And they started using ivermectin last August. Not as aggressively as they learned to do this year, but they started using it because they did a study in healthcare workers, and they found that if healthcare workers regularly took ivermectin, none of them were getting sick. So they made a statewide protocol that all healthcare workers should take the drug. And you'll see back in August of last year, they had a big rise and they adopted it. And then they had a very slow decline, and they really had almost no cases for a long period of time. They were outperforming most of the world. So then what happened in April and May? Well, in Uttar Pradesh, they have millions upon millions of migrant workers who go to other cities, leave the state for work, and then they come back home. And during that massive catastrophe in April and May, many, many millions came back to Uttar Pradesh and brought back COVID. Because as you all know, COVID ravaged India in April and May. And so there was this very, very sharp spike of cases. But look at the equally sharp decline. They went to airports, they went to bus stations, they went to train stations. They did massive testing, and they treated everyone with ivermectin. They gave ivermectin to every positive case, as well as ivermectin to all household contacts, as well as ivermectin to these massive teams of healthcare workers. I mean, this is public health at its finest, because it wasn't just the ivermectin. It was one of the most coordinated and one of the most aggressive case surveillance, case identification, surveillance of contacts with quarantining, and they did it in a very, very organized fashion using a huge healthcare workforce. And so this is what has been reported this month, and it's just not getting out there. But I will tell you, what Uttar Pradesh achieved rivals the eradication of smallpox and polio. And it should be in the history books for all of time, because I will tell you, they eradicated COVID from their state. And how do we know that? They're one of the most aggressive, they are the top testing state in India. And if you look, the 2 weeks prior to September 20th, the last 2.5 million tests, 2.5 million tests, they had 201 cases, which is a positivity rate of 0.004%, which is effectively zero. They'd had only 24 deaths in the entire state over the prior 2 weeks, and they had majority of their districts in the state had no new cases and or active cases. And I will tell you, this appeared in multiple national newspapers in India, and the WHO even wrote up a huge, very glowing laudatory piece on what Uttar Pradesh achieved. Guess what word was missing from all of those newspaper articles and all of those bulletins? You did not find ivermectin or early treatment mentioned at all. It was only about their case surveillance and case following. And I will tell you, it was not vaccination. In fact, the cases were already ridiculously low in early August when fully vaccinated was only 5%. By August 31st, it was 16%, and now it's much higher. But I will tell you, the cases had already disappeared by that time. So it was not vaccination. And so why is ivermectin not the standard of care? Well, it depends where you are. If you look at what's called the West, so Western Europe, North America, you will not see ivermectin being used. But it's breaking out, especially in Central and South America and some of Eastern Europe and Southeast Asia. You're seeing more and more adoption, either fully or partially. And so there are a number of health ministries that know that this works. But I will tell you, the power of the pharmaceutical companies and the media in suppressing ivermectin is massive. And it's scary. And it's the thing that I learned as a doctor in this pandemic. As much as I learned about this disease and how to treat it, I also learned how science is corrupted in medicine. And so when you want to ask why ivermectin is not being used, is because of the hundreds of billions of dollars who are opposed that need ivermectin to disappear. Why should ivermectin disappear? It's because it is a repurposed drug. It costs pennies to make, and therefore it has many, many enemies. And if you think about the enemies, you have to talk about the entire vaccination industry, all of the manufacturers. They know how effective ivermectin is in prevention. If people were to use that in prevention, it would pose as a direct competitor. And so you'll see this attack, and you see these immense fingers of these influences of this opposition. The other thing is that the emergency use authorizations might be removed if they played by the rules, if this was shown to be effective. And the other thing is, it is a direct competitor to numerous novel oral antivirals, which they're bringing to market. If anyone's paying attention, right now, there's a media storm over Merck's new molnupiravir drug, which apparently led to 47% reduction in hospitalization or death, which is half of what ivermectin does, which reached that in Argentina, that was 88%. But guess what's going to be standard of care very soon? It's going to be the very expensive novel Merck drug. So you have to understand why there's competitors, and as well as numerous other things that use monoclonal antibody use would decline. Remdesivir would be gone. Very few people would need remdesivir because very few people would go to the hospital. And so I'm really tired of this. I mean, it's a worldwide fight, and it's literally a crime against humanity, and it's causing hundreds of thousands and millions of deaths because of the suppression and this fake controversy over this drug, which is literally the penicillin of COVID. And I'm just tired of talking about this. If you look at remdesivir is a joke. Look at this meta-analysis. Now you guys know what forest plots look like. Look at the benefit of remdesivir. This is where Paul Marek and myself, we split up the trials done by independent investigators versus those by pharmaceutical companies. All of the benefits are in the pharmaceutical company trials. All of the others actually have a trend to harm. And this is used all throughout the United States at $3,000 a dose. It is absolute corruption of science. And if you compare the two, it's not even, we don't even need to. You all know that it's not even close. One is pennies. And then we just lived through what I call Pharmageddon, which is a month of attacks on ivermectin throughout the media, the state departments of health, the CDC, all putting out bulletins, the FDA, do not use, it's a dangerous drug, and it's not shown to be effective. It was Pharmageddon, and it happened because of this simple fact, is that doctors and patients know it's effective, and the prescription shot up in August, and that's when they turn their guns and they're trying to suppress and diminish the use. And it was all done, in my opinion, due to yesterday. It was all done to prepare the entry of Merck's oral antiviral drug. And so this is what pharmaceutical companies done. I just want to tell, the last thing I want to say is ivermectin is a repurposed drug. It is not the only enemy of pharmaceutical companies. They have been attacking repurposed drugs for decades. It is part and parcel of how they operate. Ivermectin is just the latest of the repurposed drugs, and it's probably the one that is poised to create the most harm to all of those competing products. And for that reason, that is why we're constantly being told that it doesn't work, that it's dangerous, and that it's controversial. And this is some of the bombs that they started to do throughout all of our society in the United States, attacking, dismissing it as a horse drug, and that people are eating horse dewormers, and caricaturing people as being stupid enough to use animal drugs and conflating that with an animal drug. It's been disgusting. And so I will tell you, though, it's not working. In the United States, despite this Pharmageddon, throughout the media and throughout all of the agencies and societies, the prescriptions continue to rise. Doctors know that it works, and patients know that it works, and they seek out. The prescriptions are still flowing. There's a lot of barriers, but it's going. And so with that, I'm going to stop and just say this is what happened yesterday, and it was all over the news in the United States. It is absolutely monopolizing all the news, and it's that Merck has a new oral antiviral pill. But I will tell you, I wouldn't take that if you paid me. I would take ivermectin every single day of the week. And so my last slide is that although it's a viral syndrome, it's highly treatable. It's not just ivermectin. There's a number of other agents, almost all of them repurposed, which have very high efficacy in treating this disease. And as with any acute disease, you want to start early. And I will tell you, ivermectin has the most evidence for early treatment and prevention. And what Uttar Pradesh accomplished, centered around the aggressive use and prophylaxis of ivermectin, is literally one of the greatest achievements in public health. And with that, I'll stop. Thank you.
Thank you, Dr. Kory. Diana, can we just ask a few questions because we are
thank you. Thank you.
I'll let you go, but
thank
we'll
you,
have a few questions. And
so much. It was very interesting and very dynamic and energetic presentation. Thank you, Dr. Kory, to open our eyes on the real situation of the kind of treatment scenarios in relation to COVID management. So, because in Sri Lanka, the parents are more concerned about children simply because the country has already opened. Now, very soon the schools are also being opened in gradual scales. So, one of the common questions that has been posed by most of our participants are how effective this in children, how safe to be used. Because even for the ministerial guideline is from Sri Lanka, it's not very much clear about using it. Most probably they discourage use the drug for the minors. So what is your opinion on it?
So of all the studies that I presented, none are in children. So we would have to borrow the clinical reasoning based on the safety in parasitic diseases. So it has been used widely in children across the world for decades. So we know that in parasitic disease models, single dose or 2 doses are very safe. We also know it has unparalleled safety in adults. And so it's a weight-based drug. I cannot think of a reason why you couldn't use it in younger children. In fact, it's been used unfortunately, it was used to treat Norwegian scabies in HIV-infected babies, so severely immunosuppressed. They used it to treat even young people. The only warning is that it's considered you shouldn't use it in children under 6 months of age, and that's because of a not fully developed blood-brain barrier. But after 6 months, there's really no safety concerns. You could treat it. Now, we haven't really been advocating. We don't have a pediatric protocol because generally children fare pretty well with this, and we're not pediatricians. But I will tell you, with Delta variant, we are seeing more severe illness in some of the children. And so I think it's reasonable to treat a child. Again, if it wasn't such a safe drug, and like I said, in that state in Argentina where they treated 3,000 patients, they followed those patients carefully. They checked liver function tests. They monitored for side effects. And in a very high dose, which is 0.6 milligrams per kilogram, which is 3 times the dose of a standard dose for parasites, and they did that for 5 days in a row, they found no adverse effects. And and I have a whole document of high dose ivermectin. It's very hard to hurt someone. But again, everything in medicine is risk versus benefit. And so if the risks are very low of a child developing a severe illness, then maybe you don't need to treat it. But I'll tell you, this disease is moving fast. The variants are really confusing. And I will also say long COVID to me is devastating. Long COVID comes from only one reason. It's from under-treatment of this disease. If you treat early, especially with ivermectin, you don't get long COVID. And I know that it's happening to children as well. So there are reasons why you would want to treat a child. But again, I leave that to the individual physician. But I will tell you, I do not see a safety concern around treating a child based on its decades of use in children with parasitic diseases and even in COVID with adults. It's weight-based. You would just give them a lower dose. And I can't imagine why you would run into trouble with a child and not an adult.
Okay, thank you. Thank you, Dr. Kory. I think that clearly explained about the scenario. So, but how would you recommend to use the use of the drug as a prophylactic measure for the children?
So my expertise in ivermectin is, I've been immersed in studying the drug, the disease for many months, but, I'm part of a group in an organization that's called the Frontline COVID-19 Critical Care Alliance. And we're a group of experts who came together with only one mission, which is to develop the most effective treatment protocols for this disease. And so if you ask me, how would I treat or how would I prophylax, I will tell you, go to our website, which is flccc.net, and we have prevention, early treatment, as well as hospital treatment protocols. And we also have a long-haul protocol, which also we use for vaccine injuries. I will tell you, ivermectin is really effective in long-haul COVID, as well as in those who have problems with the vaccination. Again, because it tightly binds to the spike protein, so it neutralizes it, and it also affects the monocyte. So what we now propose, we used to do ivermectin once weekly. The problem is, then we ran into breakthroughs with Delta. Delta has much, much higher viral loads than the prior variants. And so we saw breakthroughs on our once weekly dosing. Now we've gone to twice weekly. Again, everything's risk benefit. Have we found any safety concerns with twice weekly? No. And we know many people around the world who are using twice weekly, but we think that would give you the most protection.
Okay, thank you. I would remind the website mentioned by Dr. Kory, that is flcc.net.
Three C's, flccc.net.
Okay, flccc.net. Please go and search it for more information. I would like to ask one more question. How is the prevalence of post-COVID syndromes for the people who were used with ivermectin? Have you done any kind of research on it?
No, so I don't have organized data. I do know that that's mostly from clinical experience. I'm sorry. Sometimes I speak only from clinical experience. I don't have the trials data to support. But it's been my experience, along with others who are expert and use ivermectin regularly, we have just not seen long haul. Like all the patients I've treated, none of them have come back to me saying that they have long haul symptoms. I do have long haulers, but these are patients who never got treated, who I'd never treated. And so those are my long haul patients. So that's the only thing I can tell you. And I will say that observation is mirrored by others who use ivermectin.
Okay, I think it is very much clear then. The thing is, there's no clinical research evidence for that. So my last.
Well, there's one evidence in fluvoxamine, which is another drug that we use in COVID. It's an SSRI and has a number of trials showing its efficacy. And in one of the trials, they found that in the treatment group, none of them had long haul, but in the placebo group, I think up to like 30% or higher had long haul symptoms. And so I use that drug as a model for early treatment prevents later symptoms of long haul. But that was not ivermectin. It was another effective early treatment drug.
Okay. Thank you. Then my last question and the most controversial question, I would say. When I, when I decided to moderate this discussion, I just did some of the web search. Then when I was very much interested about the WHO stance on it. Unfortunately, I found that their last update in 13th March 2021. This is nearly 4 or 5 months before. So what they still say is the current evidence of use of ivermectin to treat COVID patient is inconclusive. Do you have any kind of understanding their present situation? After 5 months, their stance may have been changed.
So I wrote a full white paper dissecting what the WHO did. You're asking me, I'm going to give you my honest opinion. I'm a New Yorker, I'm blunt, and I am absolutely exhausted with all the corruption. But I will tell you, and this has been well described over the last 20 years, the WHO is under regulatory capture. They are captured by many interests with non-scientific objectives. And one of the most absurd examples for the degree that they are captured is that document that you just mentioned, the March 31st update on ivermectin. If you look at it, you will see that they ignored a huge part of the randomized controlled trials evidence base. They ignored all of the observational studies, and they refused to look at any study in prevention. They essentially looked at 16, and then they divided them into little piles, and they found that there was inconclusive. It is what they do. In fact, it is my opinion that that committee, or whoever wrote that document, they had one objective, which is to write a document in which they could not recommend ivermectin. I just told you what the opposition to ivermectin is. And I know where the funding comes from for the WHO. There's no way they were ever going to recommend ivermectin. It would be the standard of care worldwide, and it would obliterate the market for all of those other products. And so when the WHO, and I wrote a white paper detailing everything that they did, it is absurd, it is not subtle. And the last thing I will say is when I pointed out those examples of scabies and strongyloidiasis, how the WHO managed to make a recommendation for those on a minuscule evidence base, well, it must have been because there was this pandemic of scabies which cratered the world and destroyed economies, so they felt like they had to do a bold move. I don't remember the last scabies pandemic, all right? So that shows you how absurd they're behaving. The other thing is, in the history of WHO guidelines, all of their guidelines, especially around diseases with repurposed drugs, they always have low to moderate quality, at best moderate, most of the times low, and almost all of the time it's observational studies. Nobody does high quality RCTs for cheap repurposed drugs. And so you can pick out of the hat any WHO guideline for any disease that they've done in their history. You will not find nowhere near the evidence base that there is for ivermectin. It's corruption, 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 period.
Sure,
Thank
sir.
you, Dr. Kory. Can I, from the chair, thank you? Because I know what a busy person you were, but I also understand your passion for the subject. So I let you go beyond the time given to you.
Yeah, thank you. I didn't
never
keep
do.
track of time. I'm sorry,
No.
but thank you.
But it was interesting, and I think people benefited from it. And I want to thank you for accepting our invitation to be here today. And we benefited from you. And as Dr. Jeevanta said, we will maybe write to Tonya and give her some of the questions, the bigger, the really intricate questions to you, and we look forward to an answer so that we could then communicate by email to the participants.
I'm
So
happy to
thank you
do
very
so.
much.
Thank you.
Thank you very much. And look after your health also, because
I got it.
The next item on our agenda is the introduction of our next speaker. And I'd like to call upon Lion Manjula Ranasinghe to introduce Dr. Lenny Da Costa.
Very good morning, evening to everyone. And to some, let me say very good morning too. Dr. Lenny Da Costa, a consultant, geriatrician, penetrative cardiologist, and an anti-aging specialist. He did his basic MBBS from the Goa Medical College and completed his specialization in geriatrician medicine from MS Rahima Medical College in Bangalore. He is further undergone in training in the practice of anti-aging and preventive cardiology. He is certified by the International Board of Clinical Metal Toxicology, USA as a FCMT. He is also been certified by the American Academy of Anti-Aging Medicine in the field anti-aging medicine. Dr. Da Costa is a member of number of members of organizations including IMA, CGP, Research Society for the Study of Diabetes in India, GPA Greater Mumbai, and Geriatric Society of India, to name a few. He is currently the president of Society of Regenerative Aesthetic and Anti-Aging Medicine in India, called SRAAMI, president of the Indian Society for the Study of Metal Toxicology and Chelation Therapy, scientific advisor to the World Academy of Anti-Aging Medicine Asia, WAAAM, executive council member of the European Council Aging Research and Training, called ECA. During the course of his practice, Dr. Da Costa has lectured in various conferences and teaching workshops on anti-aging therapies using the use of chelation, IV, nutrition regenerative therapies, metal toxicology, preventive cardiology, BHRT in generic cases, IV therapies for diabetics, etc. He is a faculty member of the International Board of Clinical Metal Toxicology and Indian Society for the Study of Metal Toxicology and Chelation Therapy, ISSMTCT, and he's been a member of the teaching faculty of number of national and international workshops for doctors. So let me now present Dr. Lenny Da Costa from New Delhi, India to you. Over to you, Dr. Lenny Da Costa.
Thank you. Thank you for the gracious presentation. I think I'll share my screen and I won't waste your time. But just a correction, I come from Goa, not New Delhi. I do have a clinic in New Delhi, but I do stay in this lovely state of Goa, which is on the west coast of India. Okay, can everyone see my?
Yes, yes.
And am I audible?
Fine.
Yes.
Fine.
Minute. All right. So what I'm going to be speaking to you now is about the Indian story. You have had a very eloquent presentation by Dr. Kory. I'm not going to get into it, into anything that he has said, except the fact that the UP story will be repeated. So in this session, we are going to be talking about the background of what happened in April 2020, when COVID first hit us, March, April 2020. What the first and second waves were like in India and the Indian response. The treatment protocols that we used, I mean, we were in the private practice, so I'm not someone who's representing the government or anything that the government has done or any of the establishment in medicine. I'm mainly talking from a very private perspective where individual practitioners like us had to face the fact that we needed to treat our patients irrespective of what happened, and we'll see how that went. The UP experience, of course, and of course their plans going forward as well. And then we'll look at some numbers in the states that used ivermectin in our own country and those that didn't. So let me begin by just this background document that was released by our Ministry of Health right as the first wave started. This was on 31st of March 2020, and I just wanted to highlight this to you. That time in 2020, 1.5 years ago practically, we didn't know what to do with COVID. And so this was one of the things that the Ministry of Health did come out with. They said you could use hydrochloroquine and azithromycin. Nobody was talking about ivermectin then. But there was some noise about ivermectin going on in Australia. And so by June, when towards the end of May or June, when hospital crisis in major parts of our country started, specifically in Bombay, I still remember in Mumbai, I was getting calls from my patients there. I have a clinic there. I couldn't travel then. All travel was shut down. So I was in Goa, and I was getting calls as to people telling us that they didn't have place to put their patients in now or their family members in because the hospitals were packed. And so we needed to get something out. And at that point in time, nobody could get to a doctor. Doctors were not available. Many of the practitioners, private practitioners in Mumbai were dying. So there was a fear. And so most people were only working on WhatsApp, giving advice on WhatsApp. So that's when this thing happened. People would go to hospitals only if they were getting a space or a bed there. And so at that time in the private sector, this was what was being prescribed. And ivermectin at that time just came out with, ivermectin was available in India. It was being used, like Dr. Kory said, for so many other things that has been in India. It's available over the counter. We use it for worm infestation and so many other things. And so doctors started using it because they had read something about it. You need to understand the first wave though. The first wave, you did get your symptoms by the 5th day after getting, or 3rd or 4th day after getting the infection. And then you went on, if you ever got into the hospital, it was around the 8th or the 9th day. So the so-called cytokine storm would be coming in and hitting you on the 9th day, 8th, 9th, or 10th day. That was the first wave. And so when we were treating people used to come to us only after their testing was done. And so they would land up with us around the 5th, 6th, or 7th day, just before, if they would get a cytokine storm, that would be the time. And so when we would put all these medications on them, many of them improved. And so this was our understanding, that people who were getting it on time didn't land up in the hospital. So when people started understanding this, the panic reduced. And that panic, as most practitioners started using this, and the panic started reducing, the numbers also started coming down. So the one thing that we felt actually reduced numbers after a lot of the common practitioners started using this. And then this happened to be even in the government kits. So in my state, for example, somewhere in June, they said, okay, you don't need to be in the hospital if you have COVID. If you don't have too many symptoms, stay at home. So at home, people were given kits. This was the same thing that went into the kits, right? Ivermectin, doxycycline, or azithromycin, vitamin D3, vitamin C. Of course, the dosing was different. It was much smaller, lower, and magnesium and zinc were given as a multivitamin and multimineral thing in that kit. So even the government was distributing this towards the first wave as it started waning. And so towards September, though we were having a lot of people who were getting into hospital, it was not bad. The hospitals were not overwhelmed. We were now kind of in control of it. And we also started towards August of last year, not this year, towards August of last year, we started giving the same treatment. The moment we saw any patient in a family getting or testing positive, we would give treat the entire family. Not the kids, but the adults. Everyone would get this before even they were tested. So that's kind of cut down the spread, because ivermectin also helps in cutting down the viral load, the shedding of the virus that an infected person does. And so that helps basically when you start giving it to your family members as well. And so post that, the official protocol, if you look at it, this was what the official protocol was like from the government of India for a long time till the second wave hit us. And let's see what the official protocol actually said. It actually spoke of ivermectin or hydrochloroquine to be used in patients with the help of your doctor's advice. So this was what was being told to us till about when the second wave hit us somewhere in the month of March. But before I get there, what were we doing with patients who were in the ICU? Many of us in the functional medicine sphere started using this right up from August of last year, what I put on your screen. We have used glutathione, IV vitamin C, and many other high dose of melatonin, vitamin D every day. This same protocol, of course, with lower doses, after the FLCC protocol came out somewhere in November or December, many of the hospitals, the corporate hospitals started using the same thing. They started using vitamin C, much lower doses than what we were using, and they were seeing results of people getting better. We used this and we saved a lot of people. I still remember one of the first persons that we managed to get out of hospital was a doctor, a good friend of mine, a senior physician, who actually called me up and said, Lenny, I don't think I'm going to survive, because he says, even with very high flow oxygen, I can't breathe. And I'm slipping on my stomach, I can't breathe. So that's when we got to his doctors and said, hey, let's try this protocol and see what happens. And on the fourth day after that, he was out of the ICU. So this is what happened with ICU patients. We did continue using the oral medications that were being given as well. We advised them, but many people wouldn't do it in the ICU. So this at least they followed. Now, post that, somewhere in the month of October, between September and November, this study was done, and this study came out and was published in February of 2021. And what did it say? This was with regards to prevention, using ivermectin in prevention. This is what Dr. Kory also spoke about very eloquently. But this was a study that actually kind of paved the way for using ivermectin even by many other doctors who were earlier than that or before that were using hydrochloroquine for prophylaxis. So what did this study say? The study typically said that the 2-dose ivermectin prophylaxis at a dose of 300 micrograms per kg with a gap of 72 hours was associated with 73% reduction of SARS-CoV-2 infection among healthcare workers for the following month. And so chemoprophylaxis has relevance in containment of the pandemic. And so once this came out, a lot of the doctors started using this for themselves. We still continue using it. We give it out as prophylaxis, despite the fact that it is not on the official status. And we'll come to that story in a moment. Now, the second wave hit us somewhere in end of March, April of this year. And that was bad. So what did we do? We had just a little bit of modifications there. Why? Because in the second wave, what was basically happening, and this was the Delta variant, what was happening was too many people were getting infected too quickly. The testing was taking time. RT-PCRs were coming after the 3rd day. And the cytokine storm was hitting people by the 5th day. So it was too late to get started on anything. So the moment anybody felt that he was sick, had a headache, a fever, we thought the best way is to give this out. And we kept a check on one more parameter, and that was the heart rate. The moment the heart rate and the fever rose, instead of paracetamol, we preferred to use mefenamic acid. And there was reasons behind it. There are studies behind it. I won't get into that. And that kind of helped us. We also used the same protocol for prophylaxis as well, like we had done in the prophylaxis, in the sense people who were the close contacts of anyone who got infected, we gave them the same protocol. And so this helped us to some extent reducing the load on the hospitals, because the hospitals were overwhelmed. A lot of people were reaching the hospital because many people didn't even feel a fever or anything, but by the time they got the fever, they got tested, they were getting hit by the cytokine storm, and it was very, very fast. So when people started understanding this, treating very early helped us to start curtailing the numbers going forward. And that is what helped a lot of people not get into hospitals. I still remember in the month of May this year, November 2021, I used to get calls from Delhi specifically, and we used to just give this and tell them, hey, listen, besides this, if you need anything, if it doesn't help, get an oxygen cylinder, keep it with you, but just start this. And at that point in time, 12 milligrams is not what we were doing. Sometimes we would go up to giving a double dose of 24 milligrams per day. And we used to do it because these were easily available. 12 milligrams is something that was available on the counter. If you had to calculate it and tell them take 2, 3, it might have been difficult. So we used to say, okay, take either 1 or 2 tablets, depending on how severe the case was. Many patients benefited on this, and that's how we were able to kind of curtail it. Most doctors were giving this out. This was in the private sector. The government sector was actually so overwhelmed that they were just trying to help people survive and give them oxygen as far as possible. We had the highest number of deaths in that time. And so at that point in time came the story of UP or Uttar Pradesh, where Uttar Pradesh was seeing a huge peak. On May 27th, it was huge at that point in time. So what the government did was, with the help of WHO and the CDC, both helping the UP government, they actually had teams moving across villages. Now, what they were doing rapid testing, not RT-PCR, rapid testing, and anyone who tested positive, the entire family was given a kit, and the entire family got treated. Exactly what we were already doing in treatments earlier. And so they went out and started doing this across their 75 districts. And they did this over 5 days. This began on May 5th. And this was in the most populous state in our country, 230 million people, 231 million people there. This is what helped UP to curtail it. And what happened there was, just 5 weeks later, on June 14th, the cases had dropped by 97.1%. Uttar Pradesh program was hailed as success all over, but nobody told anyone, not even the Indian newspapers had what was in that kit. Nobody mentioned it. Z News, one of our major channels, which news channels or a major television producer, came out with the thing that strategy of trace, test, and treat yields results. They actually came out with a big story on this. The state also registered a steep decline in the number of active COVID cases, as the figure had dropped from a high of 310,783, that's 310,000 practically, or 311,000 cases in April 2021, to just 8,986 in June 2021. So July 2021, on July 2nd, specifically 3 weeks later, the cases had come down by 99%. So this was one of those major success stories. And mind you, around that same time, the official protocol of the government still had ivermectin, that private practitioners could use ivermectin and HCQ and inhalation of budesonide. This was still being bandied around by the government till towards the end of May, when suddenly, this was what the UP story which happened, ivermectin was introduced, you could see it for yourself. But then what happened was, somewhere in the end of May, there was news that there was a case filed against Soumya Swaminathan. She's from India. She's an epidemiologist who is one of the key decision makers at the WHO and the World Health Organization. And that is when the government kind of said, okay, listen, we need to. And she had come out with a statement saying that ivermectin should not be used. It has no effect, or something to that effect. And this is what happened. The Union Health Ministry the Directorate of Health, General of Health Services, or DGS, issued a revised guideline for management of COVID patients, dropping ivermectin, hydrochloroquine, and favipiravir, along with others, which were widely used by private practitioners and hospitals across the country. But while they said this, what happened was the guidelines actually differed from those provided by the health ministry, their own ministry, which recommends both ivermectin and hydrochloroquine. So there was a lot of confusion. So the states, individual states, see, health is a state subject among the states. So the individual states decided to continue using whatever they were using, and they went with their own guidelines. And that is what saved states like UP, because UP did not follow this directive. They continued with using ivermectin and other things that they had in that kit. The new guidelines were issued on May 27th and also did not mention taking steam inhalation and use of vitamins for COVID treatment, which again contradicts the advisory of the health ministry website. So the website said something and these guidelines said something else. And so to top that, around June 2021, around the 25th of June, if I'm not mistaken, Hindustan Times published this article where they said the Chief Minister of UP launched COVID-19 medical kits for COVID-19 symptomatic children. And what did he launch? And I think this will answer a lot of questions that were being asked to Dr. Kory as well. And I'm going to quote here what the Chief Secretary said. Mohan Prasad said that the medical kits contain paracetamol tablets, ORS packets, multivitamin, and surprise, surprise, ivermectin tablets to be administered to symptomatic children in the interim till their samples are tested for coronavirus following the admission to healthcare facility if found positive. Medicine supplied in the kits can also be used to treat seasonal fever, he said. The kits were prepared based on suggestions given by medical experts and pediatricians. Now, this was the kit that they launched to ensure that the third wave, which was supposed to hit the kids, didn't hit. And this is what they launched. This was the official version of the UP government in June of 2020. On August 6, 2021, India's ivermectin media blackout, meaning the entire world, across the world, including the Indian media, never spoke about what was in those kits. Finally, MSN acknowledged that what was contained in those Uttar Pradesh medicine kits was, among others, had doxycycline and ivermectin as well. So that's the first time ever that anybody spoke of what was in those medical kits. While CDC and WHO said they would give a huge white paper and a huge document on what they did in UP, that document has not seen the light of the day because they have to be honest about what they used and they don't want to tell the world that they use this drugs that are officially called off by even the Indian government. So let's look at the numbers like I promised. And this is something that will kind of make you understand what is the true story here. Uttar Pradesh was on ivermectin. Population was 240. This is somewhere on August 5th. These are the August 5th, 2021 numbers. Only 4.9, about 5% were fully vaccinated. COVID cases, 26. COVID daily deaths, 3. This was on August 5th, 2021. Delhi, on ivermectin, population 31 million. Vaccinated, only 15% fully vaccinated. COVID cases, 61. COVID daily deaths, just 2. Uttarakhand, on ivermectin, population 11.4 million. Again, only 15% fully vaccinated. COVID daily cases, 24. Daily deaths, 0. Let us look at this. On the same day, August 5th, 2021, I'm not even going to Tamil Nadu. I'm just looking at Kerala, a population of 35 million or 3.5 crores, all right, population of 35 million, reported that they had 31,000 cases, all right? And what was their vaccination? They were close to 50% fully vaccinated. But they were not using ivermectin. What happens? Sorry, they were 33% fully vaccinated. What happens in the United States, the country that we all look forward to to see what happens. Their COVID daily count at that time was 127,000, and daily that's for 574. In fact, we have another. I couldn't put that slide here because I just couldn't find it. But there was another statistic that was given. 6 Indian states with a total population of 410 million had less number of cases than the whole of United States, which had a lower population, because these 6 states were using ivermectin and they were not having vaccinations over 30%, even around 15 to 20% was what fully vaccinated was in those 6 states. So that is the Indian scene as it stands today. We are going full speed ahead with the vaccination. But what the government has done, despite the fact that it has officially withdrawn this for whatever reasons the WHO has put on them or the pressures that WHO has put on them, the state governments continue doing what they have to. They have not stopped us private practitioners from using whatever we want to treat our patients. Today, Goa, which was totally shut down, is opening up. We're back to our tourism. We've opened up the casinos just last week. We are back to doing everything normally. Yes, the masks are there. Yes, the distancing is there. We've got practically a good 70-80% of our population having got the single dose of vaccine and about 30% fully vaccinated. But our basic protocols are the same. If there are people who get, even today, if somebody comes to me and says, I've tested positive for COVID, the protocol is the same that I just showed you. With that, I'd like to thank you for giving me an opportunity to give you a brief presentation of what the Indian scenario has been. It's not the official version, but it's what we experienced on the ground, and we were the ones who actually went out and fought this. I wish you all the best in Sri Lanka to do whatever you all need to, but always remember something. Not always is science right, because when you talk about being absolutely true to science, then you need to be absolutely true to science with all that you use. You can't be true to science when you are using ivermectin and looking at studies of ivermectin, and you can't be not true to science when you're using vaccines that are not fully tested. So you need to be, as a doctor, I believe that we need to question everything. There is not a single vaccine that was launched before this COVID-19 vaccines which were not tested for a long period of time. Here we've got tons of studies and safety data on ivermectin, and we want to ignore it. And we are willing to embrace the vaccines just because certain experts are saying it's safe. Then why did we actually go and become doctors if we are going to believe in experts and not our own conscience? So my call to everyone, think before you advise, look before you step out. There is a lot of evidence for ivermectin. Use it if it suits you. Use it if you think it's going to benefit your patient. With that, thank you for giving me this opportunity. Thank you, Lion Shirley, for calling me in. I'll stop my share, and I'm willing to take a few questions.
Yeah. Shall I start then?
Yes.
Yes, Dr. Dayanand, please go ahead with the questions.
Yeah, Dr. Costa, we all should really thank you to open our eyes to a hidden information, and being a general practitioner who is dealing with people in your day-to-day life, your experience would be definitely beneficial to most of our Sri Lankan physicians who are in this forum, as well as the physicians all other parts of the world. So therefore, I would like to start with the place where you stopped. Sri Lanka, we are doing very well in vaccination. We have already vaccinated more than 53% of the total population. It's a huge task, but still we see COVID-related deaths and some of the other consequences of it. Then what is the kind of rationale between it? What is the kind of if I get fully vaccinated, still should I use the ivermectin as a prophylaxis? What is your call on it?
So let me explain this to you in a little different manner. See, when do you use prophylaxis? You use prophylaxis when you have a lot of cases around you of the illness, that is when you want to do prophylaxis. Now, many parts of the world, or especially in our area now, that there is a lull in the number of cases, you would not normally use prophylaxis. If you are vaccinated fully, and if you have got, please understand one thing, from whatever we have seen, just being fully vaccinated doesn't mean you're not going to get the infection. Chances are you will get the infection, you won't know it, you'll go and spread it to somebody who's a non-vaccinated. That is a bigger problem that we have been seeing. So what does ivermectin do? One of the things when you use it as a prophylactic for ivermectin, one, you're using just 2 doses or 3 doses. Second, it's not going to harm you. Third, if you're having any side effects of the vaccine, it will save you because it like Dr. Kory said, it binds to the crown protein. So it's saving you from any side effects that may crop up maybe 6 months down the line. That is what some of the COVID vaccines are supposed to be doing. And that's what some of the data that's coming out is showing us. And the last thing it will do is, if you do get the virus, you will not spread it to others because the viral load is contained by the viral shedding is not done by ivermectin. I mean, it contains the amount of viral shedding done. So it's got 4 benefits that you're having. Why not? Why won't you do it? If you have cases around you and you're worried that the cases might go up, why won't you do it?
So what you're trying to explain is these magical drugs work as the treatment as well as the kind of prevention. Because if I infected with COVID, if I'm on Ivermectin, so then the virus load that I'm spreading to the whole society is less.
Yes,
then it is a means of prevention.
Yes, it is.
Okay, that is very much.
That is one thing that has been ignored by a lot of people, and there is a lot of data on this as well.
Okay, thank you for bringing this up. So what is the kind of how would you choose the patient or individual for the prophylaxis treatment? So that is another question.
So prophylaxis, like I said, what we did was everyone whose families were affected, suppose say there was a person who got infected, he was tested positive. The next thing is you tell the rest of the family to go and get your RT-PCR done. RT-PCR would come in 2 days. By the time if they were infected, they would get the full-blown disease. Even before the RT-PCR came, there the prophylaxis starts, right? You start giving the patient right away that itself.
Okay.
So that way you contain and you don't let it spread out.
Okay. So do
we allow those patients to go out? No, we tell everyone to home contain themselves.
Okay, then that is the kind of prophylaxis part. When it comes to treatment, most of the doctors may be beneficial. What is the best dose of drug? What is the common drug regime that you are using?
So we get a packaging here in India of 12 milligrams.
12 milligrams.
And so we generally use 12 milligrams unless it is a little late in the day and the patient is already with high fever, and then we may use 2 for either 12 to 24 milligrams over a period of 5 to 7 days. In our second, if you looked at one of my slides, in our second wave, we extended that to 10 days. We didn't want to take a risk. We said, use it for 10 days. Even if you're all right, just use it.
Okay. Thank you. It is very much clear. Then there's another question. The use of promethazine. Some of the parts, especially one of the participant, Dr. Chetty, has asked another question. The using of promethazine is one of the practices in especially the areas such as South Africa. Do you have any kind of experience? What is your call on it?
No, we have not used promethazine in India, or at least not in our practice. But we were using other molecules like melatonin, which also helped a lot. And there is a lot of data on that as well. High dose melatonin went up to 10 and even 20 milligrams a day.
Okay. Then we'll assume that I have received the both vaccines. Then I'm fully vaccinated. Then in that case, is it advisable for me to use this drug for kind of prophylaxis or any other things?
So that is a decision that your doctor will have to take depending on the kind of exposure that you have. So I would always say, take your advice from a clinician who is open to everything, who believes in everything. Take an advice from him. See the kind of exposure that you are exposed to, and if you think that you need to take it, yes. I would suggest, I would actually put it to the administrators is, if you are actually seeing, despite your vaccination, there is a sudden surge in your, that's what happened in India, because as you were vaccinating, suddenly there was a surge of cases and second wave came in. You need to use molecules like ivermectin, which will help you to contain that surge, and at the same time help you carry on with the vaccination. So why are you doing the vaccination? Well, the world wants you to do the vaccination, but the vaccination sometimes does give you problems. So if you want to curtail that problem, yes, you have a product and you actually may not require the vaccination at all if you continue with this. But because you need to do it, because you need to travel, because you need to do so many things, and everybody wants you to get vaccinated, you go get yourself vaccinated. Tomorrow you get hurt because of that vaccination, you are stuck. That there is always, if your doctor feels there is a need that you need to take it, I think you should look at it as a good prophylactic.
Responsibility that we are in the schedule.
Okay, thank you very much, Dr. Jeevant, and thank you, Dr. Lenny. Like I said earlier, you have been a great help to me to organize this. You have given me a lot of advice, which I'm very grateful to you. So you must be happy with what you see here today, and let's hope that we'll benefit from your presentation and your advice given to us. The next item is the introduction of our next presenter. May I call upon Lion Mayuruthan to introduce Dr. Tess Laurie.
Thank you. Thank you, Chairperson Governor Shirley, to give this opportunity to introduce Dr. Tess Laurie. I'm delighted to introduce Dr. Tess Laurie. Dr. Tess Laurie, UK MBBS, and UK MBBCH, and PhD holder. Dr. Tess Laurie, Director of EBMC Squad, CIC, and founder of the British Ivermectin Recommendation Development Initiative. It's called BIRD. And also, she's a steering committee for the World Council for Health, WCH, and director, the Evidence-Based Medicines Consultancy Limited. Now, I kindly invite Dr. Tess Laurie to do the presentation.
Hello from Bath in the UK. I'm Dr. Tess Laurie, the Director of the Evidence-Based Medicine Consultancy and also EBMC Squared, which is a community interest company. I have no conflicts of interest, and I look forward to speaking to you today about the evidence on ivermectin. In 2015, the World Health Organization published a very important document called Research Norms for Public Health Emergencies. During a public health emergency, researchers and journals have critical roles. Every researcher in a public health emergency has a fundamental moral obligation to share preliminary results. The onus is on the researcher to disseminate information through pre-publication mechanisms, and journals should encourage the sharing of relevant data because in health emergencies, information needs to be shared urgently. In the past 7 months, as a systematic reviewer and guideline methodologist, I have been involved in a review of ivermectin for the prevention and treatment of COVID. This review was published in the American Journal of Therapeutics at the end of June. For this evidence review, we asked 2 questions. Firstly, does ivermectin work for the treatment of COVID-19 compared with no ivermectin treatment? And secondly, does ivermectin work to prevent COVID-19 compared with no ivermectin treatment? We found 24 randomized controlled trials in 15 different countries. 21 were treatment trials and 3 were prevention trials. Most were registered, self-funded, and clinician-driven. There were lots of observational studies that unfortunately did not fit our inclusion criteria. We found several preprints that we included. We included many outcomes in our review, but the one we considered the most important was death. 15 trials contributed data to this outcome, which involved almost 2,500 people. We found a 62% reduction in deaths, which meant in absolute terms 2% of people in the ivermectin group died versus 8% in the control group. Due to concerns about one particular trial by Al-Ghazal et al., we excluded this trial from our analysis. On doing so, we found the results still clearly favor ivermectin, showing a 49% reduction in deaths on average. We also looked at serious adverse events or side effects. There were 11 studies that contributed data, and there were very few serious side effects. For studies that looked at ivermectin for prevention of COVID, we found an 86% reduction in COVID infections with ivermectin compared with control groups. There are now 10 reviews that suggest benefits with ivermectin when used for COVID. None of these reviews show harm. There are 2 that show no benefit at all. One must remember, though, that these reviews only include randomized controlled trials, and when the wider body of evidence is evaluated, there is a 1 in 1 trillion chance that ivermectin doesn't work for COVID. Whilst ivermectin has evidence at every level of the evidence pyramid, it seems that regulators are only looking at one review. The recently published Cochrane review by Pop et al. Only includes 4 studies with data on mortality, and they split these data up so that they only have 2 studies in each analysis. By splitting up the trials, most meta-analyses consist of 1 or 2 studies each, and this dilutes the findings of a benefit in favor of ivermectin. Pop et al. Ignores several trials that were published as preprints, and also unpublished but available data. They ignore trials that compared ivermectin with other treatments, and they also attempt to discredit the work of others. Even the World Health Organization's findings differ. They included 7 trials involving 1,419 people in their analysis of mortality, and showed an 81% reduction in deaths. They also found very few side effects and no difference in side effects between ivermectin and the control group. Ivermectin is now already in widespread use, and real-world data and frontline doctors consistently agree that ivermectin-based protocols work. Honduras has been using an ivermectin-based protocol since April last year and have managed to keep on top of COVID infections and COVID deaths. Similarly, we have seen from real-world data in India this year that when ivermectin is introduced, COVID cases and deaths fall. Some authorities have raised concerns that using ivermectin may be dangerous. However, we know from mass administration campaigns in Africa that ivermectin is extremely safe. In addition, we see that those countries that have been using ivermectin routinely to prevent river blindness have much lower rates of COVID and COVID deaths than those who don't. Reassuringly, the World Health Organization's pharmacovigilance database shows that very few adverse events have been reported for ivermectin since 1992. This is what one would expect from a World Health Organization essential medicine, after all. To qualify for inclusion in this list, a drug must be supported by sound and adequate data demonstrating safety, efficacy, and consistent performance in a variety of medical settings. Ivermectin is the key to getting life back to normal. Thank you for listening.
Without any delay, call upon our first Vice District Governor, Dr. Anoma Vijayasinghe, to give a closing remarks.
Past District Governor Shirley Tisera and District Governor Raj Kumar and all the participants and the doctors. Thank you very much for inviting me to do the closing remarks. Chief guest welcome all the participants and showed us about the importance of the vaccination. Chairperson spoke about the quality of life we have along with the COVID vaccine. When it comes to doctors, Professor Saroj Jayasinghe, he had the task of issue and challenges faced by Sri Lanka. Then he said about challenges, very successful vaccination campaign we had, 4 to 6 weeks to reach the adequate immunity. And he spoke about the transmission, then transmission will be less. And he highlighted about the Delta variant, which is fast spreading. Then about the vaccination, he said it's the most important part in Sri Lanka. After the second vaccination, 2 to 3 weeks time, we develop the immunity. Then vulnerable period takes a high, he mentioned. And he measured to reduce the spread by limitation of the transportage, avoid crowd, and to do the safety measures and limit the mobility of the people. Then it comes to ivermectin. He said exploring all the possible experience. But he spoke about what is ivermectin, why consider using it, and strength of evidence he used. What do you use if you evidence in conclusion? Then he spoke about river blindness in 1988 and it was helped by using ivermectin. Sri Lanka already had used this particular drug for head lice, scabies, and it was in the essential drug list. 40 years used this drug, 4 billion doses he mentioned. And he studied about the computer stimulation pathway and all the members then he showed us about how the virus reach the membranes and penetrate the tissues and goes to lung.
Thank you very much, Vice President Governor Dr. Anoma Vijayasinghe. We come to the last item on our agenda. I know we have gone about 15 minutes beyond time, but please forgive us because the subject is so important that I didn't want to stop anybody midway so that we get the best benefit of these excellent speakers we had got here today. So for the vote of thanks, I'd like to call upon our second Vice District Governor, Placidus Peter, to propose the vote of thanks.
Chairperson of today's event, District Governor 1991-1992, and Shirley Tisera, and respected faculty, present and past leaders of Lions, Leos, and dear guests. It is my present task to propose the vote of thanks. Is ivermectin an effective treatment for COVID-19? This was the discussion that we had, and we heard a lot of information. We heard a great deal of information on the above subject from finest and eminent speakers today, and this was possible due to the hard work and a lot of time spent on meticulously planning this event by the team led by chairperson of today's event, Past District Governor Shirley Tisera, and also advisor, District Governor of Lions District 306B1, R.L. Raj Kumar, PMJF, and also his spouse, Lady Marian, and advisor and faculty of today's program, Emeritus Professor of Medicine, University of Colombo, and consultant, Department of Medicine, University of Sabaragamu, Sri Lanka, Professor Saroj Jayasinghe. I can't forget the team today. Lion Dr. Jivanta Pereira, District Cabinet Secretary of Lions District 306B1, Lion Manjula Ranasinghe, Chief Administrator IT Operations, Lion Senthil, Global Leadership Team Leader, Lion M. Mayuradhan, Deputy Cabinet Secretary, Dr. Dayantha Ranatunga, who has 13 years experience as Country Manager of UN Joint Programs on AIDS, who was one of our facilitators. Lion Dr. Nihal Adhikaram, Chief District Coordinator, COVID and Communicable Diseases, Lion MP Sri Bhavan, and Lion S. Patmaraja. Your initiative and time spent in putting this program together, to which we have an international audience of Lions, prominent doctors, professionals, Lions, and many guests. Today, you have shared important and valuable information. Today's staff performance, if I say, are our guest speakers, starting from Professor Saroj Jayasinghe, who gave an invaluable opening to the dialogue and shared his experience and knowledge on the subject. And then came Dr. Kory from USA, who shared his experience and the results that he had seen in using this drug. In his own experience, he was very clear in his information. He was very, very professional in what he said. And then Dr. Lenny Da Costa, who is from India, who has seen and used this drug in their own practices, and Uttar Pradesh, where they have shown fantastic results on using this drug. And also Dr. Tess, though she was not present, who was cordial enough and very humble enough to share a recorded message to us. I believe your time spent today, the knowledge and experience shared on Ivermectin and its possible use against this pandemic will be extremely useful to all of us. We, as the Lions of District 306B1 and Sri Lankans, appreciate your commitment, and even with time differences running up to even 10 hours, joining us from various parts of the world in this virtual platform, or as we all have come to terms, as life's new normal. First Vice District Governor, Dr. Anoma Vijayasinghe, who gave us the final take-home message, providing us with the closing remarks of today's program. Our question moderators, Dr. Jivanta and very specially Dr. Dayantha Ranatunga, you have done an extremely well, and thank you very much. Your expert handling of the questions gave clarity and answered many questions that the participants had. Finally, you each and every participant without whom this program would not have been successful. Starting from the chairperson to each and every one of you, let me say a very big thank you. Stay safe, stay healthy. Over to you, Chairman.
Thank you very much for thanking everybody. Well, I'd like to close the meeting, but before that, may I thank you again from the chair for being here today in numbers. I think we have on our YouTube channel, we have many participants. On the Facebook Live, there are many participants. So altogether, it's quite a sizable numbers. We'll keep in touch with you. Your questions will be sent for answers, and we'll be communicating within 7 days. So the meeting is closed. Thank you very much. Please look after yourself. Your health is most important, because we need healthy people to kind of fight this battle. Thank you very much, and may God bless us all. Thank you.